Hello and welcome to the Midwest Reproductive Symposium International Podcast, MRSI Talks ART, the latest advances in IVF. I am Dr. Angie Beltsos, founder and CEO of MRSI. Our podcast is dedicated to experts providing single subject exploration into advances in IVF. Thank you, Ferring Pharmaceuticals, for your continued commitment to education by sponsoring this podcast. Today, we welcome Dr. Eric Forman, who is the Medical and Laboratory Director at Columbia University Fertility Center. He oversees the medical practice as well as the IVF embryology and andrology laboratories. Dr. Forman has extensive clinical and laboratory research experience and has published over 50 articles in peer-reviewed journals on a wide range of topics in ART. Dr. Forman is also the immediate past president of MRSI and its current program director. I will be joining Dr. Forman, and again, I am Dr. Angie Beltsos. I'm a double board certified OBGYN and reproductive endocrinology and infertility doctor, practicing medicine since 1991. I completed my residency in OB and GYN at Loyola University in 95, followed by a fellowship in REI at Washington University in St. Louis, Missouri, completed in 97. I've participated in a number of research projects and scientific publications every year. And I've received many awards in teaching and honored as a top doctor for Castle Conaway for several years. I am fortunate and proud to be a popular speaker both nationally and internationally. And I often serve as a frequent media resource on the topic of infertility. It is also my honor to serve as the executive chairperson for MRSI. Dr. Forman explores when euploid embryo transfer fails. Welcome, Dr. Forman.
Hi, Eric. Dr. Forman, how are you?
Hi, Angie, Dr. Beltsos. I'm great. I'm here in New York, and it's great to see you again. Looking forward to seeing you in Chicago this summer.
Yes, July 26th through the 29th, 2026. We're going to be in Chicago at the Drake. I cannot wait. We always have an amazing session, so much to learn and be connected. I think that opportunity is just one of the delights of the summer is the Midwest Reproductive Symposium. And we're really excited about our podcast.
Yeah. It's great to keep up with, new developments in our field, even leading up to the meeting. So hope that this becomes a regular thing and looking forward to having a good conversation with you.
So today we're going to talk about recurrent implantation failure. And I can't think of anyone in the world that would be better to have this conversation with than you, Eric. You've done so much work on this topic personally with your patients and also in research. So today we want to talk about recurrent implantation failure, RIF. And so we've put together this little patient case that I'd like to share with you and the audience. So if you're good with that, I am going to, just get my computer plugged in here so it's happy to. So this is a 37-year-old female G3 P2022. So her story is that she has a little girl that's 3 years old. She had a vaginal delivery of Phoebe, no complications. And then after she stopped breastfeeding, they got pregnant again. Unfortunately, that ended in a 6-week miscarriage. She passed it on her own, and they did not do any testing. She wasn't getting pregnant, so she ended up seeing a fertility doctor. They did a workup on her. She tried Clomid IUI a couple times. It didn't work, so they moved on to IVF. So her first IVF cycle, she had 4 blasts created, and they decided to skip PGT. So no PGTA was done. During her workup, they noticed a small fibroid. It was adjacent to the endometrial cavity, but not distorting the cavity, and it was not removed. And she did 2 frozen embryo transfers, but did not get pregnant. They changed the protocol a little bit, and then in her third try of 1 embryo, she did get pregnant. Unfortunately, she miscarried, and they did test the products of conception, and it was a trisomy 16. So they decided to do another stim, another IVF cycle, and this time she again made 4 embryos, but they did PGT on her fresh and her frozen embryo that remained. So now she's ready for her next frozen embryo transfer. So I'll pause there and let you kind of talk a little bit about failed implant.
Interesting case, not so different than a lot of patients we see, you probably see. Recurrent implantation failure is a controversial topic in general. There's not really a consensus definition for it. Definitions, I think, have changed over the years as our field has changed, where it used to be even transferring like 10 or more embryos when we used to transfer like, 3, 4 embryos on day 3. Now, some people, even will do workup after 1 failed transfer of a normal, chromosomally normal or so-called euploid blastocyst. Whether it's even a true phenomena or condition or just sort of like a statistical, mirage, some would say, one, is another controversy. And there are those again who feel like, everyone should be worked up for all possible causes, even things that have less sort of classic evidence behind it, and others that feel like, this is a very rare situation that we know that there's just limitations to IVF and embryo transfer. And so at least one group that I was part of years ago, met and reviewed a lot of evidence on this topic, and think that not complete consensus, but a lot of people, I think, accept that after 3 euploid embryos have failed to implant, that's unusual, still could just be bad luck, for lack of a better term. A lot of this field that we're in is luck and probability, and even when everything looks perfect, like a perfectly normal, chromosomally normal AA blastocyst and a uterine lining that's 8-9 millimeters, trilateral, it doesn't work at least a third of the time to a half of the time, depending on, different labs and clinics. So something doesn't work half the time, like flipping a coin, if you got tails 2 or 3 times in a row, you wouldn't think that I'm never going to get a heads, that there's something wrong. But it's natural. Obviously, there's so much emotional, financial, physical energy invested that if one transfer doesn't work, and often that's after, maybe many months or years of not working at home or other things, that it's understandable why people would, wonder if there's some implantation issue. Again, this kind of review, looking at data, if we think that it's a common thing that a significant proportion of our patients have true implantation failure, then if you really look at just the probability of it, we would expect that after 1 or 2 failed transfers of normal embryos, that the success would drop off dramatically, because those people would be the ones, there would be more of those people that truly have some barrier. But the good news is it actually success stays, pretty good, like 50% or higher. And there's even been some studies looking at the 4th and 5th transfer without necessarily changing a lot of things. So that first point is just that it's probably rare. don't have a clear-cut definition, but after three transfers of embryos that should have a really good chance, that's where I think, we start to pause and look deeper. Although that being said, we should always, I think, do a very thorough evaluation and feel confident that the first transfer is going to work. So that this, often comes up with patients, like, are you going to change something? If we felt really confident, we did a good evaluation of the uterus. You mentioned for this patient, there's a small fibroid that we don't think impacts the inside of the uterus. So presumably she had a saline sonogram or an HSG or a hysteroscopy, again, then
Looking at that
wouldn't
uterus.
necessarily change something after one transfer didn't work. And this patient, three transfers that were not tested embryos. In fact,
Yeah.
the third one we know was not normal and wouldn't have been transferred if PGTA had been done and accurately detected that trisomy. So she might have failed two transfers of euploid embryos, and we don't know. Maybe
Yeah.
only
So
one of those was normal. Maybe none of
the,
those were. So if you're looking at untested embryos, then it's a higher bar because you could transfer three untested embryos at 37, there's a chance they were all abnormal or only one.
right.
At
And
27, that's much less likely. It's more likely that all were
something
normal
else.
or
Yeah.
maybe was abnormal. So that's where PGTA, I think, comes into this discussion, is that it doesn't make the embryo, normal. It doesn't make the embryo better. Some people think it might even negatively affect it. That's another debate, but
Yeah.
it gives you more information that at least you're transferring embryos that have, the
So
correct number of
the
chromosomes.
correct number. So I have a question for you. Can we go back for a moment for our audience? And I know a lot of the audience is aware of the American Society of Reproductive Medicine, ASRM, as well as the European Society of Human Reproduction and Embryology, which is ASHRAE and ASRM. And so these organizations try to help us define, even just to say, what is recurrent implantation failure? And what you just said had kind of summarized it. Could you tell us again what might be like criteria of when we talk about recurrent implantation failure, the quote unquote definition? And you said it's kind of hard to define. I think even the organizations struggle with it.
Mm-hmm. Yeah, again, I don't think it's limited to just like number of transfers. And I think that's kind of an older approach, like
Right.
two or three failed transfers, because again, if it's a day three embryo or someone in an
The
older reproductive age
circumstances.
group, their chances of that working are very low. So if you're transferring an embryo that has a 10% chance, it's much more likely that three transfers will fail. So for example, in this, one, review of these factors, really like the number of untested embryos. If you figure, like we said, that patient who's 37, maybe a third or more of her embryos are expected to be abnormal. So how many untested embryos would you have to transfer to feel, confident that there should have been like a 95% chance that at least
Right.
one maybe? Because if all three were normal, again, there's a study looking at transferring one normal embryo, transferring the next normal embryo, transferring the next normal embryo, and about 95, over 90% of patients, couples, were able to have a successful pregnancy. But again, if those weren't tested embryos, it really, the age affects the risk that those embryos might have been abnormal. And so if
Yeah.
you transfer more, then you have to be really unlucky if you transfer like seven untested embryos at
Right.
37, that most likely at least two or three would have been normal. And so, again, at that point, though, like your patient decided to then do PGTA, and control that variable, which I think made sense. She had a loss at home, that we don't know,
It,
might have been normal. She had a loss that was confirmed to be normal. A bigger, I think challenge for us is when you then do the testing, you have normal embryos and you're transferring and those are not implanting. Then what do we do? Your patient,
yeah,
I feel good about her prognosis that if she can make a normal embryo, she has a pretty good chance because, that trisomy 16 embryo implanted. You should make sure her uterus gets back to normal. Whatever FET protocol you used, at least you got that implantation to happen.
great. Well, I think the take home for us is that the definition depends. It depends on the person's age, depends on what you transferred. And like recurrent pregnancy loss, RPL, and recurrent implantation failure, with a strong embryo, let's say a good uterus and two good blast euploid transfers, that if that didn't work, then that certainly may be a starting point of saying, are we missing anything? Sometimes you just want to make sure your workup's done. So in that, what would you say in this patient? She's going to do her first PGT euploid transfer. She's proven she's had a baby. She's had embryos implant, but now we're looking for going all the way to a live birth. So at this stage, would you do anything further for her workup? Like, how do we test a patient who is, we've decided she has recurrent implantation failure? Now, what do we do with her that you would make sure that we test for?
Yeah, so again, that's a great question. And, like I said, my approach, I think, is to do a thorough evaluation, even before the first transfer. Patients will
Yeah,
often, they don't want to wait to fail 3 transfers and then do a certain test, or they don't want to wait to have 2 or 3 miscarriages. That being said, again, we don't want to necessarily do testing that hasn't been proven to be helpful or add things that haven't been proven for everybody when most of them, like 95%, will not need that. So I think, again, a lot of the success of our treatment is related to the embryo itself. And, morphology is not perfect. There are, again, newer ways of looking at that, time lapse and AI. And I think we need more evidence to see if that's actually better than an experienced embryologist. But not all euploid blastocysts are the same. So, most labs use the Gardner grading, AA, A, B, C for the trophectoderm inner cell mass, the expansion stage, the day the embryo reaches the blastocyst stage. A lot of clinics now culture until day 7. Day 7, even chromosomally normal embryos in most studies have a significantly lower chance of success. Day 5 and 6 are usually pretty similar in most labs, but most embryologists prefer if they had the choice, day 5 over day 6. Some studies show slightly higher success. Even age, I mean, we've kind of assumed, for a long time, I think that once you get a normal embryo, age doesn't matter. But there was at least one like large review of thousands of transfers of normal embryos that in a more advanced stage, not only does it get more difficult to make the normal embryos, even 1, let alone 3, when you get
yeah,
beyond 42, but there may be other factors beyond just the chromosome number about the quality of the embryo, its chance of reaching its full potential of a healthy live birth, so that they
really
still
amazing.
have good, excellent success rates, but the success of a normal embryo from age 35 appears to be higher than 42, 43, but still maybe around 50%, but not 65%. So
Yeah.
there are
So
embryo
that's
factors. So one, the embryo, and once those embryos are frozen, though, there's not anything that I'm aware of that we can do to make that embryo more likely to implant. We just have to hope it tolerated vitrification and warming well. There's
Right.
some.
There's so many factors that go into this. And I
Mm,
think what you're saying is you may have tested embryos or untested, but you're going to rank them of your tested based on what they look like, how they developed, and there are going to be markers of speed to development. Yes, they all they cross the finish line, and those that did it in a timely manner, day 5, 6, may be a little stronger than those that took a little longer to get there, even though they all got there. And, there are other studies looking at how fast embryos divide and develop using time-lapse imaging that you had mentioned. And also, we're going to continue to learn maybe the role of mitochondria and things that we don't typically test for, maybe playing a role in picking the best ones. So we're going to rank the embryos. We've ranked them, and we did the best we can with what we have today. Now, what other tests would you do in regards to this patient before she does another transfer? And is there anything about the fibroid that you would do further in regards to the testing? She had a saline sonogram before her transfers that showed that the fibroid was about 3 centimeters and it was close to the lining, touching the lining, but not distorting it. Now, today, what would you recommend she do before? And maybe there's nothing to do with the fibroid, but curious, anything else, mock cycles or blood tests?
Mm-hmm. Yeah, so that's again a great question. Saline sonogram is a very common imaging modality we use in the US, but it varies from clinic to clinic.
Yeah,
Some prefer hysteroscopy. If you're not sure, sometimes the fibroid can be very close, like you said. With hysteroscopy, you can feel, you can lower the pressure, you could see if it actually protrudes in. If it doesn't, I'm kind of more of the school of thought that in general, like less is more, and I wouldn't want to go sort of digging for a fibroid that's not really protruding and impacting the
yeah,
cavity. Because if a lining otherwise looks perfect, we know this last miscarriage wasn't because of the fibroid,
of
most
the
likely
uterus. Yeah,
trisomy. So, and everything has risks. Even trying to remove a fibroid, you could cause scarring or injury to
yeah,
happen. So I think even 3 centimeters is relatively small, not proven to impact implantation, especially if it's not impacting the cavity. Um,
would you do a hysteroscopy to look at this one, or?
again, not necessarily. I think if you
Great.
got really good, she has a really normal lining and a really clear saline sonogram with smooth walls, and you could see the fibroid, you see that it's not impacting. I wouldn't necessarily. Um, I think
Would you
one area
do?
that's maybe sometimes overlooked is whether an HSG is necessary. Like this patient got pregnant naturally through her tubes twice, should be low risk of having hydrosalpinx, but not zero risk. Sometimes after a prior delivery or miscarriage, that can,
Sure.
or secondary infertility, she could have endometriosis. Um, so it should at least be thought of, like whether it's doing a really good, ultrasound,
Right.
looking where there's not obvious hydros, or when you do a saline sonogram, making sure you don't see it.
I
Some
love that.
prefer
That's a
HSG
really
to be
that's a
more
really
definitive, but
important point, because I think a lot of people that do salines, and I've seen so many reports, they're like normal cavity, and I'm like, and did you see anything in the adnexa while you were there, paying attention to the fallopian tubes? And I personally think that, like maybe you as well from bringing it up, is that if you're really want to look at fallopian tubes, there are new techniques of using an ultrasound guided tubal test that are great, and they can use bubbles or foam, but also the HSG is a great tool to really look for any tubes that might be swollen, that might be causing the embryo not to implant. And one study had shown that if there are swollen tubes or hydrosalpinges, that the pregnancy rate with a transfer could be cut in half. So I think you bring up a really good point for anatomy. What about endometrial biopsies for any signs of inflammation or chronic infection? Do you do any of those at this stage?
Yeah, that's a great question. Another sort of, I think, one that we don't have the definitive answer. Like there are some studies associating endometritis with miscarriage, I think more than implantation, but maybe implantation as well. Even how we define endometritis
Yeah,
is, I think, not a clear like gold standard that if you sent the sample to different places, you would definitely get the same answer, and
yeah,
or that we as physicians would interpret it the same way. So I think there are some groups like looking more into this, but it would be nice to have more standardization of how do we actually define this. It's reproducible. We agree on what it means and it's clinically relevant. There's even a study from Richard Scott, my mentor's group years ago that looked at patients who were having a normal embryo transferred, and they did this biopsy that you're referring to, endometrial biopsy, and looked at CD138 cells, plasma cells, but didn't look at it in real time. They just did the biopsy, then the next month did the transfer, then they went back and they quantified. And you would think, if there was some association, the ones that had more of these, CD138 cells would have lower implantation. And they didn't really find that. It didn't really associate. And, I would like to see a study of, a bigger study like that. Or there's some who, there's always critiques in retrospect of how
yeah.
they defined it, how they counted it. Is it the same as if you sent it to your pathologist? So I don't think everyone necessarily accepts that, but that was intriguing that maybe it's not associated with implantation. So
I
like,
I'm
it's
curious about,
not a test. There are some things like I just don't think there's enough evidence for, and I won't do. That's a test that my practice will test for and treat
you will do a biopsy.
not routinely before every
But
transfer, because again, I think that's invasive and
yeah,
hasn't shown to be helpful, but unexplained euploid losses, especially, maybe again,
yeah.
euploid
It's worth,
implantation failure.
what I love about talking to you is you refer to the literature and what we have tried to understand in researching this topic in the world. And then you and I both have to sit down with a patient, a couple, and say, okay, here's what I would do next. So biopsy could be a consideration for you or your patient. What about the
Give you an example,
protocol?
real world
What's your,
example. Just like not that long ago, having this discussion, I remember after I think two transfers didn't work, said, should we do a biopsy? That takes a cycle. It's uncomfortable. Then you might have to do antibiotics. Then do you repeat the biopsy? Even that's not so standardized. Is it 10 days,
right?
2 weeks, 3 weeks? Do you just treat it and presume
Go
it's
on.
which usually it is? Do you repeat? We don't have definitive studies on that. And this couple said, oh, let's do one more transfer, and if that doesn't work, then we'll do that. And we did that transfer and it worked. And so she's pregnant, quicker than she would have been if she went through this, uncomfortable test, maybe
Yeah.
antibiotics, side effects. So, for every
I've had,
story here of someone that's like, I did this and I found this and the next transfer worked, there's at least as many or more that, recognizing that each embryo is different, each transfer is different, even the same patient, same doctor, some I think we overlook even the transfer itself. Like sometimes it's really easy, gentle, we get the embryo right where it needs to be. Sometimes it's a little tricky for some reason, the way the
Right?
bladder is filling, the way
And
the
that
womb.
could be, it could be, let's call it iatrogenic, or just when a procedure is done, sometimes placing a catheter into the uterus isn't always as straightforward as we would like, based on anatomy or the person doing the transfer. That's a great point. What's your go-to protocol in regards to the medicine or no medicine that you use for your first transfer?
I think that's changed over the years also, which is interesting as we've gotten more data and experience have shifted, our practice has shifted. So, so one, I think the data, like randomized trial data we've reviewed when we've looked at how euploid embryos perform is very reassuring that there's a variety of different ways you can prepare the uterus, the endometrium, and get basically the same results. So I don't think
Yeah.
there's like a protocol that's better than the next. But, I think the field was more dominant on programmed, medicated, and there's a lot of advantages to it, especially for large, busy clinics that have lots of patients and have embryologist and can even out how many transfers land on any given day or avoid weekends if they have less staff.
Right.
And even for the patient perspective, some of our patients are very busy with work, they travel a lot, they want to know you come in for 2 3 visits, your transfer is going to be this day with your doctor. That's still great, we do a lot of that. But for patients who have regular cycles, who ovulate, even who've been pregnant naturally before, like the patient you presented, a modified natural cycle transfer is also a great option. We know from really well-designed trial, led by Kate Devine, who's a frequent speaker at the MRSI conference from Shady Grove, that when you do those program cycles, you should include progesterone and oil intramuscularly. Hopefully there'll be new options like subcutaneous progesterone eventually, but some clinics recommend that every night. Some do a hybrid with vaginal and every second or third night. Some patients prefer intramuscular. They don't like placing things vaginally, but most patients, when like studies and surveys have been done, prefer not to have intramuscular injections for
Right.
several weeks. So modified natural cycle is, I think, more patient friendly and is at least as successful. There's actually been some recent studies. One was, I think, won a prize at last year's MRSI conference, and I think is in press, that looked at if you did a transfer of a euploid blastocyst and it didn't work. It wasn't randomized, but if the doctor or clinic decided to repeat the same protocol, just say, like we said, probably the embryo, everything looked good, let's just do the same thing.
Swing the
Or
bat
they said,
again.
oh, let's, we did medicated, let's try natural. We did natural, let's try medicated. We don't really know why they changed, if it was just patient preference or just to try something different. But at least suggesting that if medicated transfer didn't work and you switched to natural, they actually saw a higher success than if they kept it the same. Or the vice versa was not actually true. If they did a natural cycle first and that didn't work, and then they switched to medicated, it wasn't better than if they just did natural again. So it wasn't just like switching for the sake of switching. It seemed like those who failed a medicated transfer might do better with a natural cycle. So
Yeah. Well,
so
that's
if
interesting.
patients have the flexibility, so it's really a shared decision. Like I
Yeah.
can't do 3 weeks in advance. Your transfer is going to be on this exact day. It can give you a window, but it depends on your body. If you can be flexible enough, if you have regular cycles, or even stimulate ovulation for oligo or anovulatory patients, will often use letrozole. I think some clinics include letrozole routinely, but if you can basically get someone to ovulate and time ovulation and do a more natural
Around the
cycle.
transfer.
That's become more of our first line, but there's
Great.
nothing wrong with the medicated approach.
Yeah, so you either give them the estrogen and progesterone, or you allow their body to make their own organically grown, their own estrogen, progesterone, and allow that to be the timing. I am intrigued as well with probably the crosstalk that occurs between the ovary and the uterus in a ovulatory cycle, and there may be some things in there that are important for some patients and their uterus to be able to speak to the ovary and vice versa to allow for an implantation. Who knows? I'm sure we'll learn more about, these peptides that are released and might be important for some people. How about the number to transfer? Would you stick with, you put one, it didn't work, you put one, it didn't work. Would you ever consider putting two, and your thoughts on that?
Yeah, great question. I mean, technically, the ASRM guidelines still, they didn't include euploid PGT till several years ago. Then they did. Once they did, it was ones across the board, regardless of age. So even if I said implantation declines a little bit, as you get, into an older age group, it's still very high, and they recommend one. It's not so clear, like, what to do. Is there a point where more than one is acceptable? Again, I think like a day 7 euploid embryo has
Yeah,
a similar implantation potential to untested embryo from an older age group, and wasn't really like the high implantation potential that led to these recommendations. And I was very involved in a trial that showed we could get very high success with single embryo transfer after PGTA and reduce the incidence of multiples and transfer embryos one at a time. But again, I mean, I do think there is room to transfer more than one embryo rarely. Again, so recurrent implantation is rare. This shouldn't be common. If you have one transfer that doesn't work, it's the second has just as good of a chance. So putting two normal embryos, you're going to have a very high chance of multiples at that point. But if you've failed, 4 or 5 transfers of high quality embryos, or the embryos are lower quality, again, they're day 7, they're BC grade, I would be open, and I think it's reasonable. I think there are some clinics that just have an absolute policy. They'll never transfer more than one normal embryo, but we will in scenarios like that. And I think
yeah,
those patients at that point, are well informed. It's not like they're, hoping for twins in their first transfer. At that point, they're not sure if they'll ever be able to, implant and deliver or shift to gestational carrier. So I think there's room for that, and we could still
yeah,
keep multiple pregnancy rate very, very low, probably under 5%. And we know it happens even with single embryo transfer. Um, Identical twins can happen. I mean,
yeah,
with modified natural cycles, we tell patients to avoid, unprotected intercourse if they're in, a situation where it
yeah,
could happen.
right.
But
That's ironic, but sometimes
multiples
it's
could still happen, and people,
right.
still
They
do
get pregnant with the transfer
I
and spontaneous ovulation, so you end up with twins.
It's happened. Yeah, we want to avoid that. So at the point
Good
that we're
point.
at, we're transferring 2 embryos, we're just hoping one takes, and
Yeah,
their true implantation potential is much less than that 60%, because
right.
unlikely that
Interesting.
4 or 5 transfers wouldn't have worked. Still, twins could happen, and if it's
Twins
someone
can
with
happen.
history of preterm labor, unicornuate uterus, something like that, I would not. But someone who doesn't have those risk factors, we
Could.
have on rare occasion.
Great. Let's move on to the last couple of points. One is to wrap up the testing piece. We talked about things that you would do. And are there anything tests that you would not do that might need better evidence, like the immunological testing, the routine, let's call it endometrial receptivity like testing, or any add-ons that you would say, by the way, take this Lovenox or take this baby aspirin or infusions?
So yeah, that's where again, like I don't think just doing things, some people assume like, why not? It must be better. It's not always better. And there is, the cost of time, which is a factor of financial cost. So, while we know like implantation is an immunologically complex
Yeah,
situation, and there probably are immune factors, I just haven't been convinced that there's reliable tests to predict that and then to act on those tests and guide our treatments. So, I sometimes see people doing like full recurrent pregnancy loss, like antiphospholipid antibodies for implantation failure. There really isn't evidence that there's an association or then giving Lovenox is helpful in that situation. So I would not do those tests. Endometrial receptivity assays like the ERA, again, have not really been shown to reliably predict this window of implantation, which we think, many think is wider than just a few hours, that's predicted by these tests. And again, that takes time, cost, receptiva or other tests, for markers of endometriosis. Also, I don't think, there's a really well-designed trial of take people that have failed 2 or 3 euploid transfers, randomize them to do these tests, act on them or don't act on them, and see that they do better. We
right.
know a lot of our patients have endometriosis, silent or otherwise. There's a, retrospective study showing that women with endometriosis who then go on to do a transfer of a normal embryo seem to have similar success as those who likely don't have endometriosis. And maybe 10 or more percent of our patients that we don't know have endometriosis actually do. And most of them go on and do well, with the first or second transfer.
Yeah.
So those are tests that I think, are interesting. And I hope, these really well-designed prospective trials are done to answer the questions of like, does it really guide our therapy? Does it improve outcomes? And then adding Lovenox, adding steroids, things like that. Also, some people do that and the next transfer works, but that doesn't mean that was why the next transfer worked. So I don't recommend those kind of add-ons.
And as we touch on that, it reminded me there are sometimes some systemic or patient factors that we might address more if they're failing. Let's talk about maybe thyroid dysfunction, diabetes, obesity, so common these days. If they smoke when they're not, even less commonly in this generation. Things like that
great.
might be things that I've had more serious, I guess, conversations with people that might benefit from, weight loss or something like that when we get to this stage to say, what else could we do? Those are things.
That's a great point. And yeah, I think of those things, I think, BMI, there are studies showing with higher BMI, lower implantation. However, there aren't great studies showing if you, rapidly lower that BMI, that you definitely improve the outcome. And we know that also takes time. So that's, again, my take-home message. It's hard to just keep going and keep transferring, but, if it's safe, in that 6 months, someone might try to lose weight and they might be successful. They might not be. They might have done another couple of transfers and one of those embryos might have just worked better. So unless we really have really good evidence that something is beneficial. Obviously, for other health reasons, someone might want to lose weight, or, we're learning more about the GLP-1 agonist. I don't think we could say yet that doing that improves your next embryo's chance of implanting, but maybe your pregnancy will be healthier, lower risk. That's fine. But we don't know for sure if the association is
Right.
embryo quality related, uterine
Interesting.
receptivity, hormonal, embryo transfer again, which we mentioned, sometimes more challenging, could be more difficult to visualize. So a lot of potential causes. I mean, one area
So,
that I think there's good evidence is adenomyosis, at least like significant adenomyosis
right. We didn't,
that is associated. So if that your patient, with the fibroid, if there's also adenomyosis, that's been associated with lower implantation potential of normal embryos. And then even then, like,
what would you do for her, for adeno?
yeah, I mean, those are patients when it's really, again, I think more subtle, mild adeno, not so clear. When it's, very significant and severe. I mean, gestational carrier is ultimate option if multiple
Yep.
trans are not working. Um, that's where I think, suppression like Depo-Lupron for 2 or 3 months, or Depo-Lupron and daily letrozole, people are looking at. Again, I think,
Right. The
again, would be nice,
dual.
better
Great.
studies. But I don't do that just, again, like for everyone, and say you fail, maybe you have this, take 3 months, because again, that's time, side effects.
Would you, so as we're kind of wrapping up today, last couple minutes, would you do comment on predicting future options to guide management, maybe AI or some of the testing that might be coming up that we didn't have before? Saliva
Yeah.
test for endometriosis, kind of. Anything else that you might add that would be easy to do? Thoughts?
Yeah. So I mean, AI obviously is changing like everything we do, but
That's true.
the way it's been used, I mean, a lot of the patients we're talking about that we're concerned if there is this true recurrent implantation failure, they've maybe transferred all their normal embryos. So an AI system to look at the normal embryos and say, I think this one is the best, based on things that maybe a human couldn't detect, but we would eventually get to that embryo. It doesn't make that embryo better. So I'm not as convinced that AI is the answer. Yes, it would be nice to get get that embryo the first time,
Yeah.
but if patients that, like I said, have used all their embryos, have difficulty making these high quality embryos. So things that could improve embryo quality, like improvements in culture, conditions that we don't really individualize. Like in a given clinic, all the patients' embryos are in similar media, similar incubators. Maybe someday that'll be more individualized to that embryo or that patient, and improve how it develops.
Yeah.
Genetics, chromosomes are obviously the key building block, but there's a lot more to that. You know, more is also not always better. We could have a whole nother podcast on mosaicism and why it wasn't, so predictive. I don't think that's the answer, but I do think that there may be other genetic markers that
Yeah.
learn in the future that some of these embryos that are normal may have some other mutations or variants that combine and prevent it from reaching its full potential.
Interesting.
Or our patients, as we sequence more, maybe there are some genetic factors that can be elucidated that predict someone has, a different way of metabolizing progesterone and needs more, for
Right.
example. Or, I think more maybe AI will help to interpret all of that, but I think the future, a big part of it is going to be more genetic on testing our patients, and maybe learning more about the embryos that are not look normal but aren't implanting.
Yeah. Well, it's been really fun diving deeper into the topic of recurrent implantation failure. I want to thank you for your time. Any last words of wisdom for our treatment teams that help take care of these patients and the patients that are listening?
Yeah, I mean, I think my take home is, to keep trying. Like I said, like one transfer not working, unfortunately, is more common than we wish, but it happens. It doesn't mean that everything is wrong and you have to go to experimental tests or treatments. And in the time that you go and do that and money you spend on that, if you transfer again, as long as you've done a good, thorough evaluation of uterus anatomy, you have a good protocol, you thaw the embryo well, it looks like a good quality embryo, and it's gently placed in a hopefully receptive environment. Keep trying, and most of the time it's going to work. And we'll keep working on that other 5% that's struggling.
So don't give up. Don't give up and stay the course. So with that open mind and this thirst for knowledge, we invite you to continue to listen to the podcasts that are coming up, and join us in Chicago, July 26th through the 29th, the Midwest Reproductive Symposium International. Big thank you from Chicago to New York to Dr. Eric Forman, who is just a brilliant mind. Appreciate you very much.
Thank you. Thanks for having me. Thanks for organizing this and all the energy you bring to the conference. So hope to see many of you there in July.
Dr. Forman, this has been a fascinating exploration of when euploid embryo transfer fails, and we thank you. If you want to hear more from Dr. Forman, join us at the 2026 MRSI in Full Bloom annual conference, July 26th through the 29th, 2026 at the Drake. Our vision at MRSI is to bring the world more babies by being a beacon of change, inspiring curiosity, pushing boundaries, advancing science, and uniting minds.